the discussions now to the broader questions that have been coming through. So we welcome everyone else to join us on the panel for discussions. So we have a few questions that have been coming through. So there is a question from Shahid Kaleem saying, would you do genetic testing for children of gene-negative HCM patients? So perhaps I can take this question initially. So we would absolutely screen people if a proband, so the affected individual, has hypertrophic cardiomyopathy, and we would screen first-degree relatives initially, unless there's an absence of a first-degree relative. So, for example, if an uncle was deceased, then their children would be screened. So yes, we would do clinical screening, but if a family has, or if the proband is negative on a gene panel, then we wouldn't cascade genetic testing unless we had a true genetic diagnosis. Perhaps, Catherine, would you like to lead the next question?
Yes, so thank you to all our speakers, and a reminder, which I should have said at the beginning of the session, which is that the talks are all recorded and they'll be available for people to watch later on. So hopefully that will be a useful resource for people. I think what's interesting looking at the comments in chat is the level of engagement around paediatric predictive testing. So Saj, Meta, on the subject, I agree, if there were clear guidelines for clinical screening, that would help. Perhaps we need some consensus on predictive testing for class 4 variants, as well as ongoing screening if negative, because he highlights, Karen, that those were areas of discrepancy from your survey. And Ruthie Recob just makes the point about making the distinction between using the term predictive testing and differentiate between treatable and non-treatable disorders. And it's really interesting, you know, the work that's being done looking at not only sort of supportive treatments, but also some of the treatments that may actually change the kind of pathological pathway of this disease. So I think this will become more and more relevant as we go forward. And what I'm hearing from these comments, from the survey and from working with teams, is that we need to get together, probably a group, to look at this. And Juan, Karen referred to your support in this area, and the AICC are keen to support a group of clinicians who want to look at this further, because I know if we open discussion now, we'll be here until tea time, and I think then wouldn't do it justice. And I'm keen to ask a number of the other questions that have come up that are appropriate for our speakers. So Claire Turner thanks you, Julia, for your great talk, and says, in the uncertainty, Julia, what's your view on the use of the R21 prenatal exome for congenital heart disease, given that time is limited because of the ongoing pregnancy, and given that there's some difficulty in phenotyping because you're looking at a fetus rather than a patient in front of you?
Yes, it is a very good question, and it's a very tricky area. I think there have been steps put in place to help a little bit with the uncertainty. So the first thing is the type of referrals. So there's very good guidance on what kind of anomalies would be considered appropriate. So the fetus has to have multiple major anomalies, and that involves a discussion with fetal medicine and different specialities to make that decision. Then once the decision is made that the referral is appropriate, although exome is being done as a trio, the analysis is actually restricted to around 900 genes that have been very well selected because they have relevance in a fetal context. And then the third thing is the view of the scientists when they're analyzing the data. There are guidelines that they will only look at variants that are clearly likely pathogenic or pathogenic. So those three levels of barriers, if you like, help a little bit filter the uncertainty. And again, it's key that they have this multidisciplinary model of working to help deal with the difficulties.
Great, thank you.
So I've just picked up another question from Ian Williams, perhaps directed to Maggie, actually. So at what level, be it regional, local, or genetic services or clinical teams, should the process of reappraisal of a VUS as applied to an individual occur? Is there a best practice nationally as to how we highlight individuals who have previously been assessed for whom a VUS then becomes pathological?
Well, we have, as part of our 2020 guidance on reporting and interpretation, we had a workshop of clinical and laboratory teams, and this subject was touched on in that workshop. And reassessing variants can be a huge workload for the laboratory. So the guidance was set on really reanalyzing variants if they hadn't been analysed within the period of the last 12 months. And it's very difficult at the moment for laboratories without the appropriate informatics infrastructure to keep monitoring everything internally regularly. And we tend to monitor and review really on clinical requests when patients or families come back to clinic and something then has come up as a VUS ahead of reporting clinic. We would then work with the clinician, with the contact, to go back and review the data on that variant, gather any new data and reassess the variant at that point if it was more than 12 months prior that variant had last been reviewed. But I think we very much hope in the future that there will be work on the informatics side, there'll be work with the variants that I meant, the databases I mentioned in my talk, such as the CVA, the genomic variant database. If we get all of the genomic information that we generate in our laboratories together in some easily mineable, updatable format, then all of these things hopefully will happen a little bit more easy for all of us and in a bit more of a timely way.
I think there's also I think this highlights also the importance of the whole team, because if in the time that's elapsed between that variant interpretation we have more information about family members and we can get additional segregation data, then of course that will impact on the interpretation as well. So just highlighting those links are so important.
That's right, and it's very much, Catherine, a dynamic process, isn't it? And I think through working in the hubs with the case that I highlighted, there's shared information that enables for families to potentially have diagnosis upgraded. So I think it's that awareness that a VUS is essentially a dynamic situation that could be upgraded at any time as more information comes available, and that information may come through various different channels at various different times.
Absolutely, and as you highlight, it's that capture point when someone is coming back to clinic that it again prompts us as an opportunity to look a little bit further and just cross-check that this has been evaluated. So, absolutely.
And Maggie, I just had another quick question for you, just on the panel for idiopathic ventricular fibrillation. I just wondered if you had any view on what the likely pickup was and if there was any preliminary data, because I know those patients were included in 100K, I think. I just wonder what your view is. And I realise you may not have been working on that panel specifically, so you may or may not be able to help.
Yeah, I'm afraid, Catherine, I don't have any data to share as yet. It's very early days for that panel. I think there has been some discussion around the gene content of that panel. And I think at the moment, the content of the panel is the same as the sudden cardiac death panel, but there's discussion ongoing as to what the gene content should actually be for survivors of cardiac arrest and where the utility is. So I think we need to, you're right, to review some data of early testing and go back and review data in 100K as well and assess the utility and try and target that appropriately for our patients.
We have an interesting comment from Graham Stewart mentioning pre-symptomatic testing is perhaps not the best term to use, as symptoms may arise a little late in the phenotype. So the 19-year-old that Melanie mentioned in her presentation was a good example about where discussions should also have taken place much, much earlier than perhaps they often do. And I know we've had lots of comments about at which age to consider screening, and that's come out from a lot of the surveys that you've been describing too. I guess the point he mentions is, are we ignoring GILIC competence and by leaving discussions later on, where major decisions, perhaps lifestyle decisions, have been made? When should we kind of really be considering this? I think the work that there's a lot of work to be done with defining protocols so that we all kind of speak from the same hymn book, so to speak, with this. But absolutely, it's having those discussions early enough and cohesively to ensure that we're all able to, that we engage families as well as children in this discussion.
And I think what's interesting, yes, and I think what was interesting from Mel's description was that the only option available to her was to discuss at the time when that family unfolded. So you had a kind of snapshot of seeing each family member at that time. That wasn't a question of waiting. They were all spoken to as the family unfolded. So I thought that was a particularly interesting case study. So Francis, I see you've written around variant sharing. Should we be consenting people for Decipher if variants will go up there eventually? So Maggie, perhaps that's relevant to you about your feeling about a sort of some kind of database of that nature.
Yes, I think that's sort of this with the whole patch of territory, isn't it, Catherine, around data sharing and data management and this legacy of genomic data. So I think we don't have a firm decision for the NHS as where the testing laboratory data will go. I think the long-term vision is that it would be part of this CVA genomic database that is the legacy from 100,000 genomes in the New Genomic Medicine Service. But currently, the only data that we can get through that channel is the data that's coming through the new whole genome sequence pathway and not the data that sits in testing laboratories, although there's work ongoing to enable that data to be uploaded. But there is also an issue then with legacy data. Decipher have a wonderful system, and they've worked quite collaboratively with the laboratories to try and find ways to upload legacy data into an NHS space within Decipher and also incorporate phenotype data. So there's a possible holding option to get things into Decipher that then could be exported elsewhere to ClinVar or to CVA in the future. So I don't think it's amiss to consider consenting people for Decipher, for the interim period, because the benefit of getting the legacy data together in one place, particularly for something like cardiac, is really strong.
We have a number of other questions coming in, or comments really about, again, education and training, for example, not just the nursing trajectory and training and education that's required, but also integrating training and education from a genetic counselling perspective. We should again be thinking about how we can develop specialist core training for GCs as well as specialist nurses.
I think we... Sorry.
No, so also comments to say that, considering kind of the patient viewpoint in developing some of these proposals and consensus work may also be helpful. Cardiomyopathy UK are very happy to collaborate in that regard too. And that genetic testing actually ranks highly on patient concerns, and they have a lot of questions that are fed back directly to them regarding that, and particularly within their research. Catherine.
Great. And maybe some of these useful resources that people are highlighting are something we could let our members know about in newsletters and the like, because they're clearly really useful resources. And we've only got a minute left. Does anybody on the panel who hasn't had a chance to speak want to offer any comments?
I'd like to pick up something quickly with Karen. Very interested, obviously, the work with the predictive testing and then how this ties in with laboratory reports and the impact of what we put in our recommended actions. It's very interesting to see people having different opinions as what they would do with a pathogenic variant as opposed to a likely pathogenic variant. And it may be for different conditions we need to work with you in the outcome of your study to phrase what we say in reports about the guidance of onward testing for families a little bit better and tie all this together, because it's very much at the moment we put a blanket statement of you've got a pathogenic, likely pathogenic variant, testing is available for other relatives, and in some scenarios that perhaps is more helpful or less helpful. So it might be important to try and tie all of this together so we can give appropriate guidance on our reports.
I think in ICC in particular, I think we just need to recognise there's a lot of subtleties in each different condition and in the genomic side of things, as well as the conditions themselves, and they're not just one big, homogenous group. And so, yes, a pathogenic or likely pathogenic variant in one condition we might deal with that quite differently to another. And I think it is quite important to get it right. But I think from my point of view, I still think that the lack of consensus nationally on clinical screening is one of the biggest barriers really to being able to take that forward. And if there was some way of consensus from a cardiology perspective as well about what time point people should be starting to be screened, how many times they should be being screened, and for that to be uniform more nationally, I think that would be really helpful.
And ultimately, again, on that point, as again, Steve Page has mentioned in the chat too, that we shouldn't forget that phenotyping often drives clinical management. So we do have to ensure that we really integrate the genotype and phenotype together. And essentially, how many children, for example, who are genotype positive but phenotype negative need to be diagnosed to prevent one major cardiac event. I mean, again, there's a lot of work to be done, and perhaps that emphasises the role for research and data collection across our services, which really should be driven from a central process. Fantastic. I mean, we've had a really informative session, and I'd like to draw the session to a close, but in doing so, to thank all of our speakers who have really delivered phenomenal talks this morning so far. So please do continue to provide any further comments in the chat should you wish, but thank you all.